Hi, good evening, good night, good night, good night, good night, everyone. Thank you so much for joining the Association of General Practitioners of Jamaica's Pediatric Obesity and Mental Health Management Seminar. This is day one. In 7 days' time, we'll have day two. We have two wonderful presenters lined up for you this evening, and we want to just right off the bat thank Dr. Peter Swaby for, on short notice, coming out to be our moderator tonight. Dr. Swaby, I'm going to hand over to you now. And as usual, if you need me, just say Sam.
Thanks, Sam. As usual, it's great to have Sam moderate, being our online and Zoom coordinator here. He does an excellent job. Looking forward to the presentations today. And it's going to be on the theme of pediatric health management in primary care in the Caribbean. Today, we are going to be hearing from two presenters, Dr. Rashida Andrews and Dr. Christella Durusco. And they're going to be speaking on childhood obesity in the Caribbean, prevention management in primary care, and that's Dr. Rashida Andrews. And then mental health in pediatrics, recognizing and managing emotional and behavioral disorders. And we all know that these are very current topics. Obesity is one of our biggest challenges, especially among our adolescents and our pediatric population. And mental health, well, coming out of COVID, we all know what mental stresses our kids were under, and that's just been exacerbated coming out of the pandemic. We've seen a lot of things. So I'm sure we have some great gems to glean tonight. We're gonna give a couple more minutes for our participants to join with us. We'll get started right away at 7:05, and I promise to keep everything as close to time as possible. I know our presenters are excellent and they're primed. We're going to keep our question and answer sessions at the end of each presentation to about 10 minutes, but you'll be able to ask questions and put them in the Q&A section of our Zoom webinar. So we're going to go silent for a little while, and I'll come back at 7:05 and we'll begin. And I want to thank our presenters for taking the time out to do these presentations for us. I know you're in different time zones. So welcome again to Jamaica virtually, and we hope to see you in person one day. Okay. Okay, welcome everyone to tonight's long-anticipated pediatric health management in primary care in the Caribbean. We have some very experienced speakers in terms of childhood obesity and mental health in pediatrics. And before we do that, we're just going to just give some housekeeping remarks and rules. Tonight, we will be having our questions put in the question and answer section. So if you have any questions, you can put them in the question and answer section. There will be a 10-minute section right after each speaker where we'll open it up for questions. But if your question is not answered, go ahead and put it in the question and answer section. And we've asked our presenters to answer those questions online. In addition to that, we have Sam, who will be taking care of our Zoom platform, and our president, the president of the General Association of General Practitioners, will not be able to be with us live tonight, but he has pre-recorded his opening remarks, and we'll be playing that. So without any further ado, let's go to God in prayer and ask him to really bless the rest of the presentation and tonight. So let's pray. Father in heaven, we're so grateful for this time to learn, to grow, and to be the best that we can be for our patients, especially our pediatric patients. Father, we pray that you'd be with Dr. Andrews and Christelle Drusco tonight as they give their presentations. We pray that it will be clear and that we'll be able to glean as much as possible. Please be with our timing. Please be with the technology. Help everything to run smoothly. And we're grateful for times like this, and also for the association putting this presentation together. We love you. We thank you. We pray this in Jesus' name. Amen. Okay. At this time, Sam, would you like to go ahead and play Dr. Donald Gordon's opening remarks for our conference?
Good evening, colleagues, speakers, Dr. Rashida Andrews, Ms. Criselda Durasco, sponsors Nestle and Indus Life Sciences, members of the technical and administrative team, and moderator for this evening's webinar, Dr. Peter Swaby. I'm Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to welcome you to the first of two of AGPJ's Pediatric Lecture Series on Pediatric Health Management in Primary Care in the Caribbean. This evening's webinar will focus on 1, childhood obesity, recognizing and managing emotional and behavioral disorders in children. The prevalence of mental health issues in the 3 to 17 years age group is estimated at around 20% in the US population. This figure represents a significant mental health issue if they are extrapolated to our Caribbean population. This evening, we have two exciting speakers in Dr. Andrews and Mr. Roscoe, who will take us through the assessment and management of the growing mental health problems in the pediatric population. As general practitioners who are not very versed in the handling of mental health issues in children, I'm sure some of these problems often go unnoticed in our general practice encounter with this age group. It is our desire that this evening's webinar will equip us with practical tips and information to manage the problems of mental health in the pediatric population. So participants, have a wonderful evening, and I will now hand you back to our moderator for this evening, Dr. Peter Swaby. Thank you very much.
And we thank Donald for doing that. He was not up to being here live tonight, but it's great to be able to have him as the president of the association. He does such a fantastic job. Tonight we have our sponsor's presentation, and I'm going to ask Sam to go ahead and do that for us.
And welcome to another Nestle education session for healthcare professionals only. The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. As our next generation of Jamaican babies grow at different pace, we only communicate responsibly with our valued healthcare professionals who can make the best decision for each patient on a case-by-case basis, from breastfeeding to supplementing where necessary and transitioning to complementary foods at the correct time. Our final group of products are designed to aid the little patients in your care to transition from their liquid start to solid foods after 6 completed months via semi-solid cereal solutions. A key nutrient identified during this transition is iron. Babies are born with sufficient reserves depicted in green and continue to receive a maintenance amount via breast milk depicted in gold. At approximately 6 months, the reserves are rapidly consumed during normal growth, reducing their levels and putting them at risk for iron deficiency depicted in red. Only an iron-containing diet at 6 months can replenish these stores to facilitate continued healthy growth. Or Nestle infant cereals with the high bioavailable element iron from ferrous fumarate coupled with 6 times as much vitamin C provides a framework to aid this transition to solid foods while bridging the gap in essential nutrients until they are fully established on everyday solid foods with their balanced nutrient needs. Nestle cereals contain more than 50% of the daily iron requirement of a 6-month-old in a single serving, at least 16 vitamins and minerals, along with probiotics, and no refined sugar added. But all our variations remain the same great taste and consistency babies 6 months and older love. Here are a few of the references for the studies supporting our features and the benefits our little patients can get from choosing our brands. For any further questions, please reach out to a Nestle representative at these numbers via telephone or WhatsApp. Do enjoy a fruitful conference. Goodbye.
Okay, great. Thanks to our sponsor for that message. And without any further delay, we are going to introduce Dr. Rashida Andrews, MD, MBA, FAAP, DABOM, is a board-certified pediatrician and diplomate of the American Board of Obesity Medicine, with an extensive clinical background in both general pediatrics and obesity medicine. She currently serves in pediatric roles at the New York and Yuma Regional Medical Center in Arizona, and previously held attending positions at Maimonides Medical Center, Peninsula Pediatrics, and Jamaica Hospital Medical Center. Dr. Andrews earned her doctorate of medicine, cum laude, and MBA in multi-sector health management from St. George's University, following a BSc in basic medical sciences and biology, magna cum laude. She completed her pediatric residency at the Icahn School of Medicine at Mount Sinai, the Elmhurst program, where she later served as chief resident. Passionate about education and mentorship, Dr. Andrews has actively contributed to resident training, curriculum development, and student guidance through the SGU Alumni Admissions Mentor Program. She is also involved in several quality improvement and research initiatives focusing on pediatric asthma, obesity, allergy prevention, and wellness. Dr. Andrews has presented at multiple academic forums and remains committed to professional growth through ongoing CME in lifestyle and obesity medicine. Her leadership, clinical experience, and commitment to holistic care underscores her dedication to advancing pediatric health outcomes and supporting the next generation of medical professionals. Without any ado, thank you so much, Rashida, for being here. Please go ahead and start your presentation.
Thank you so much for having me. Good evening to everyone. Let's just jump right in. So I have no disclosures this evening, and these are just our objectives, just broadly. So before we really dive in, just want to make sure everyone's still awake. There's no grades, there's no judgment, just a quick pulse check for us to get us thinking. So first question, and I'll just read them out. And Sam's going to bring up a poll for everyone that again, I'm not technologically savvy, but oh my goodness, thank you, Sam. So when assessing a child over 2 years old for obesity risk in primary care, which anthropometric measurement is most appropriate? A, weight for length percentile from the WHO, BMI for age percentile in the CDC, mid upper arm circumference, or a tricep skin fold thickness? I'll give people a couple seconds to pick.
Sure. So you guys have 10 seconds left.
Thank you, Sam.
No problem. 5 seconds, guys. 4, 3, 2, 1, and the results are in.
Let's see what people.
Here they go. There are the results.
Okay, so we're gonna go on to our next slide. I'm gonna close this off of my screen. Let's see. Can we go forward? So it's actually BMI for age percentile. So we're gonna learn a little bit about that tonight. So next question is, which of the following reflects current first-line management strategies for pediatric obesity in a resource-limited Caribbean primary care setting? A, early pharmacotherapy with a GLP-1 receptor agonist. B, referral for bariatric surgery. C, family-centered behavioral counseling and nutrition education. Or D, calorie restriction diets without ongoing follow-up.
Okay, again, guys, 10 seconds. Five seconds remaining. And the results are as follows.
Great job, guys. All right, so I don't have to teach you about that. Amazing. You're making my job super easy here tonight. And our last question is, according to updated AAP guidelines, what is the minimum recommended daily duration of moderate to vigorous physical activity for school-age children? A, 30 minutes, B, 45 minutes, C, 60 minutes, or D, 90 minutes?
I'll give you guys 30 minutes. No, I mean 10 seconds.
I think they're gonna get this one.
Okay.
Let's see.
5, 4, 3, 2. What's the right answer?
Oh, okay. All right. So we're going to talk a little bit about physical activity tonight. So the correct answer is actually 60 minutes. All right. So let's just dive right in. So as we've been talking about, we know that pediatric obesity is a rising public health issue in the Caribbean, with about 10 to 30% of our children actually being affected. In Jamaica specifically, there was a study done, or a survey, I should say, back in 2017. Where it found that 24% of adolescents aged 13 to 15 were actually considered as overweight or obese. So we all know if current trends actually persist, our regional childhood obesity rates will actually double by 2030. And that's going to increase our rates of our NCDs like diabetes, high blood pressure. So given this current trend, it's actually really important that we're having this conversation here tonight. In terms of just defining obesity, what I really want you to walk away with from this slide is that obesity is a disease. It's a disease the same as diabetes, high blood pressure, asthma. And in terms of a definition from the Obesity Medicine Association, and it's quite kind of a mouthful, but we'll go through it. It's defined as a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein there's an increase in body fat that promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. Kind of a mouthful. But then AAP, the American Academy of Pediatrics, goes on to further define it as typically being diagnosed using a BMI percentile for age and sex, wherein a child with a BMI of 95th percentile for the age and sex are classified as obese. But again, the whole point of this slide is for us to recognize that it's the disease, it's complex, it's chronic, it's relapsing, but it's treatable. All right, so I want us to meet our patient. His name is Kevin. He's an 8-year-old boy. He loves to play soccer, football, whatever you want to call it. He's here for his well child check, a few months of increased thirst and urination with new onset nocturnal enuresis. In terms of past medical history, he has intermittent asthma. He's maintained on albuterol as needed. There is a family history of type 2 diabetes in his maternal grandmother. He has no allergies. A snippet of his vital signs down here below. It's not full vital signs, but it's really just what we need here for tonight. So in the Caribbean, we know that we typically only go to the doctor when we're sick. And I think this is just region-wide. But parents and we as practitioners also need to recognize as well that we should also go when our kids are well, because well visits are just as important. They're great for prevention, so for doing our vaccines. These are opportunities for us to monitor our child's weight, their height, their head circumference. It's also a time for us to raise concerns. Typically for my patients, I ask them to come in with about 3 to 5 questions that they want to discuss. And this really helps us to foster a more collaborative approach to medicine. And it promotes that relationship between pediatrician, parent, child. And it really helps us to ensure that we're promoting the optimal physical, mental, and social health of this child. We typically do this based on the periodicity schedule, and this was actually developed by the American Academy of Pediatrics. I'm going to show it to you. I know this really looks really quite busy, but what I want us to notice here, and I know it's probably a little bit small for you guys, is that at every single well child visit, we are supposed to be measuring height and weight. I also want us to recognize that even though we're doing these well child visits, and these are when we should be doing that height and weight measurement, you can do these height weight measurements at any visit, whether it's a sick visit, they're coming in for vaccines. Anytime a child is in your office is an opportune time to discuss weight. And we have to really focus also on normalizing that discussion, normalizing discussion about weight status and making sure that we're doing it in a non-stigmatizing way so that the family, the child, ourselves as providers, we can then exit this visit having a more clear and practical plan to improve the health and quality of life of this child. So how do we really obtain these measurements? Because having them is one thing, but making sure we're getting accurate ones is another. So for height and length in a child less than 2, we see our baby here on the right-hand side of the screen laying flat on their back. Head is at the top of the headboard, feet at the bottom. We're applying very gentle pressure. We should not be forcing. And we're going to measure that baby from head to heel, all right? For our older children, they're using a standing height scale. They're standing up, no shoes. I know some kids want a couple extra inches, but not at the pediatrician's office. They can talk about it on the basketball court afterwards. Their heels should be touching the wall. And we want their head positioned in something called the Frankfurt plane, which is simply just that line between the lower eye socket and the top of the ear canal. We need it to be aligned. And again, like you see how that child is, heels against the wall, buttocks against the wall, back of the head against the wall. So they're really nice and straight. They're not slouching over, which is really important. For weight, we're using a digital scale for infants or a platform scale for our older children. It's really important that we get them as undressed or wearing as minimal clothing as possible. We want to do that to reduce weight discrepancies. So for our babies, yes, that includes the diaper. Please put down a chuck. I cannot tell you the number of times we had babies pooping and peeing on scales and it's a whole mess. It's like clean up on aisle 3. So put a chuck down so you avoid messes. For our children greater than 2, we want to make sure that they're standing still. Sometimes some children will want to hold a toy and we do want to make them comfortable. So what we typically would do is actually just have the parent step onto the scale while holding the child, do a measurement with both parent and child, and then measure mom or dad alone and do a little bit of quick math in the office. And for children, we want to make sure we're measuring to the nearest 0.1 kilo, and for babies, nearest gram. So we collected all this data. What do we now do with that? So for weight assessment in a child less than 2 years old, and this was one of the questions that we asked earlier, less than 2, we're using the WHO or weight for length. Greater than 2, we're using CDC, which is body mass index. So the WHO charts are really based on children from diverse racial and ethnic backgrounds who are breastfed, whereas the CDC ones are based on mostly white American children who are not breastfed. So these are our WHO charts used in our children less than 2. They're color-coded by sex. We see pink for girls, blue for boys. We know that children can like any color they want, but this is what they've done. So y-axis, we see weight. X-axis, we see length for both. We also see head circumference here on that y-axis at the top, but not really relevant to tonight's discussion. For CDC, same color coding again, but you see y-axis, you see weight and stature, and then on the x-axis, you see age. There's actually also BMI charts. So this is our BMI index for our children between 2 to 20 years of age, again, color coded by sex. And we see y-axis is BMI once we calculate it out, and x-axis being age. These are extended BMI charts. So we typically use this when assessing children or individuals whose BMI falls outside that standard BMI chart range. So somebody that has a BMI of like 40 kilogram per meter squared, it really helps us to provide us with better visualization and helps us to better categorize them as well. And it's also good for monitoring them over time as they're losing a lot of weight. So you can see that BMI go down on that curve. So I've been saying BMI a lot. What exactly is it? So it's body mass index, which is simply the mass in kilos divided by height in meters squared. We really use it as a screening and diagnostic tool for detecting excess adiposity. The reason we use it is actually because it's very easy and inexpensive. In terms of gold standard, we technically should be using a DEXA to really identify, locate, and quantify body fat. And the reason we don't use it so much is because it's super expensive and very difficult to implement. So once we do calculate that BMI, you can then plot that on that percentile curve for age and sex. I'm going to demonstrate that to you in the next slide here. I am a huge sucker for a great tool, and PROGRAMME is one of them. So if you're using electronic medical record systems, they typically will actually generate and calculate that BMI for you and may even plot it onto a growth chart that is specific to that child's age, whether they're less than 2 or greater than 2. But if you don't have that EMR, PROGRAMME is one of the really great ones. I use this all the time when you don't have a system that has an EMR. And you simply will just input the child's sex, their weight, their height, and it'll actually give you a calculation. So this is actually Kevin's data. So in the red box, you're going to see that his BMI is 24.8 kilogram per meter squared. And percentile wise, that brings him out at about 98th percentile. So you can see over here on the right-hand side on that BMI chart that we have, that he is above that 95th percentile. So that tells us that Kevin is a patient with obesity. So then we can take that number and actually classify and stage patients. So you can see here, underweight, less than 5th percentile, healthy weight is between 5th and 84th. Overweight is between 85th to 94th. Obesity is considered as anything between 95th to 99th, or a BMI that's greater than 30 kilogram per meter squared. And then for severe obesity, BMI greater than 120th percentile of the 95th percentile, or a BMI of greater than 35 kilogram per meter squared. What I do want us to walk away from the slide with is the caveat that not all patients with a BMI of 85th percentile or above have excess adiposity, and many children and adolescents who have a BMI that's less than 5th percentile are actually healthy and require no treatment. On the right-hand side of the screen, you see the classification as well as the staging system. So BMI is describing severity. And this table here is actually showing us the pediatric percentiles as compared to adult kilogram per meter squared. But what I want to draw your attention to is the Edmonton obesity staging system. Now, I don't expect someone who's in general practice to be using this. However, Edmonton is actually a really great way to measure the impact of obesity on the medical, mental, and functional aspects of the patient. It's actually a better predictor of mortality as compared to just using BMI alone. And using this framework may actually help us to prioritize, okay, like where do I send this patient? Especially when we have limited availability, especially in the Caribbean where that is an issue, and also just create individualized care plans for our patients and even decrease stigma as well. I'm not sure if people picked up on it, but I said that Kevin is a patient with obesity as opposed to Kevin is obese. So this is actually an example of something called people first language. And what that does is it actually recognizes the potential hazards of referring to our patients or labeling them by their disease. So by saying a patient who is overweight or has obesity, or a patient with obesity or overweight, is really preferred over saying obese patient, or something like Kevin is obese. And this is really similar to the standard with other diseases, such as diabetes. It's better to say a patient with diabetes as opposed to a diabetic patient. Furthermore, there's actually encouraged terms when we speak about weight. And you can ask your patient what's their preferred way to discuss it. So some people may not like you to say obese. They may prefer for you to say excess weight. In my office, I say we don't say the F word, so we don't say fat. Some people prefer affected by obesity as opposed to large size. So it's really important to understand like what is their preference, what is their comfort level, so that way we are doing that really good collaborative care and making sure that they feel comfortable. Because again, talking about weight is super uncomfortable. We're going to gather some information from our patients. So obviously your chief complaint is overweight or obesity, or is a child's weight a concern for the patient or family? So you want to ask open-ended questions such as, what concerns, if any, do you have about your child's growth or health? You want to do an HPI. So what are the prenatal risks? And we'll talk a little bit more about this later on, but what was mommy's weight during pregnancy? How was maternal weight gain? How has the child been growing over time? Was like, when did this overweight, when this onset of excess weight gain start? Have they tried things in the past, diets or exercise programs? Is there a family history? Are there obesity-related comorbidities? So for Kevin, grandma has a history of type 2 diabetes. Are they on weight-positive medications? And this is actually a really important factor because this is a potentially modifiable risk. Social history, nutrition and physical activity, and then obviously things like behavioral and disordered eating concerns, of which there are many screenings that you can find online. So things like your PSC and your PHQ-2 for depression, or your general anxiety disorder screen, and things like that. So we've gathered history and some of our anthropometric data. So the next step is really a really thorough review of systems. And this helps us to not only identify obesity-related complications, but it helps us also identify and uncover underlying causes that could influence our management approach going forward. So we remember that Kevin said he had increased thirst, urination, new onset bedwetting. And this in combination with that positive family history from grandma, I'm like, okay, are we dealing with some prediabetes here, some new onset diabetes? So these are things that are gonna kind of direct the way that I manage Kevin. But there's other questions that we can also ask during these visits. Is he tired? Is he having muscle aches? You know, that could point to a vitamin D deficiency. Is he having any in-toeing or leg bowing? Does he have some mild knee pain? Is there some Blount's disease going on? If he was female, does he have excess facial hair, acne, irregular menses? Thinking about PCOS. Some of the things that we can see on physical exam would be things like acanthosis nigricans. I'm sure we've all seen this before. So that very thick, velvety kind of skin discoloration around the neck, as well as sometimes in the axilla, sometimes even in the groin, we see it as well. A lot of times parents come in and they're like, this boy nasty, this boy not bathing properly. And you have to be like, this is not dirt, mom. This is a sign of insulin resistance. Another thing we can see is abdominal striae, gynecomastia. You see tonsillar hypertrophy down here, as well as hirsutism. Now, OMA has actually divided diagnostic workup by age. So taking a history in an infant between birth to a year, there's a couple of things that we want to ask. So I mentioned earlier, just what was mom's weight during pregnancy. You can even ask about preconception weight. And again, this is a modifiable risk factor. Is there a sibling with obesity? Was baby small or large for gestational age? Another important one, I think it's so important, especially in today's age, is duration of exclusive breastfeeding. So the American Academy of Pediatrics actually recommends exclusive breastfeeding for about the first 6 months. And we usually introduce solids at 6 months. And we can continue beyond that with breastfeeding as long as mommy and baby desire for 2 years and beyond. And what is interesting is that studies have shown that for every month that you breastfeed, you're actually reducing your risk of obesity by about 4%. One of the more interesting ones, or I think the one that I'm most interested in, is because like now we're learning that obviously health comes from the microbiome. So it comes from our gut. And we know that in pediatrics, antibiotics are the most commonly prescribed drug. So when you use antibiotics all the time, we're obviously destroying that gut microbiome. And that actually affects our energy metabolism. and may lead to obesity. So studies have been done that compare the microbiome of a child with obesity to a pair that is not obese. And they've actually found that children with obesity have increased Firmicutes and decreased bifidobacterium. And studies have also been done that compared mice where they've transferred feces of a normal weight rat to a larger rat, and that larger rat has actually lost weight. So it's all very, very interesting. In terms of taking history in children who are a little bit older, we're more so asking about things like exercise, feeding practices, other questions regarding things like screen time and sleep duration, because we know our teens are up at night on TikTok. So in terms of diagnostic workup, what are we ordering on this child? So you notice here, less than 2, we're kind of just monitoring. We're not really doing very much in terms of labs. But in a child older than 2, and this is what I typically do, baseline CBC, a CMP, lipid panel, a TSH and a free T4, hemoglobin A1C, and vitamin D levels. There are additional studies that you can do, so things like sleep studies and uric acids, etc. But these are all determined on a case-by-case basis. But those basic ones are where you should definitely start. Coming back to Kevin, again, we see his vital signs up here. We also see just like a nice little diagram of medical complications on the right. His results basically show that he is in the pre-diabetic range. He has a 6.0%. He has a fasting blood glucose of 115, so that puts him in the impaired fasting glucose category. His triglycerides are high. His HDL is low. His total cholesterol is also high. So what is going on with our friend Kevin? And then I want you also to just take a peek here at his blood pressure up top. So nearly 10% of children with obesity actually have hypertension. And when you have hypertension as a child or adolescent, it actually increases your risk of hypertension in adulthood. For diagnosis, requires 3 separate blood pressure measurements, at least 1 week apart, with 2 measurements at each visit. So many of our electronic medical record systems, allergies, Jesus, will actually calculate BP percentiles. If you don't have an EMR, there are actually apps like MD Calc on the right-hand side of the screen that will calculate it for you. So based on the data that we have from Kevin today, he's in stage 1 hypertension. However, we can't diagnose him because this is a one-time measurement. So he definitely has to come back. So in terms of evaluation, we're doing things like BP monitoring, screening for glucose intolerance and dyslipidemia. We're also assessing things like sleep history, because remember that OSA is associated with high blood pressure. And we also want to consider renal and endocrine causes if resistant. With regards to treatment, lifestyle is our first intervention. So we're definitely looking at exercise, diet, reducing his salt intake, and things like that. But pharmacotherapy is also important, but typically we reserve that for our specialists. So prediabetes, hemoglobin A1C of greater than 5.7, but less than 6.5 for 2 measurements, fasting blood glucose of greater than 100 to less than 126, or an oral glucose tolerance test for about 2 hours, where we have results of 140 to less than 200. Up to about 15% of adolescents with obesity will actually have prediabetes or type 2 diabetes. In terms of treatment, we're doing a restricted carbohydrate diet. We're repeating that hemoglobin A1C in about 1 to 3 months, because hemoglobin A1C, again, is a snapshot in time. It's something that we can work on. We also do intensive diet and exercise, because it really does improve that insulin sensitivity and promote weight loss. And we tend to think about things like metformin if we're having that hemoglobin A1C greater than 5.8%, even with that dietary adherence. So disordered lipid metabolism is actually an early marker of cardiovascular risk. And we find this in about 40% of children with obesity. There's criteria based on age, so less than 10 versus greater than 10, male versus female. We're doing that lipid profile every 3 to 6 months if it's abnormal. We should definitely consider genetic testing if LDLs are greater than 190 or triglycerides greater than 500. Lifestyle changes always come first. You really should focus on reducing things like your intake of refined sugars, saturated fats, and just overall increasing exercise and intake of your vegetables, fruits, and healthy fat. Behavioral interventions and lifestyle modification is the core treatment for obesity for all ages and degrees of severity of obesity, with pharmacotherapy and bariatric surgery really serving as adjunctive therapies for our selected patients. AAP actually talks a lot about a staged approach. So you notice here we have stage 1 through 4, we're doing prevention plus, which is basically happening in your primary care office. You are just discussing like things like 5210, better exercise, like reading labels. Stage 2 is more of a structured weight management situation. You may have a dietitian added on, a social worker, perhaps a health educator, a physical therapist. Stages 3 and 4 usually happen in a pediatric weight management clinic. And really involves just increasing or intensifying that lifestyle modification counseling. Stage 4 is typically where we would start talking a little bit more about pharmacotherapy, as well as bariatric surgery. The most effective method for lifestyle modification is motivational interviewing. So it's really a patient-centered communication style. It requires us to have reflective listening. We need to support the autonomy of the patient. There needs to be shared decision-making. And we also have to help our patient to kind of elicit change talk. So on the right-hand side of the screen there, you see the stages of change. So we go through the pre-contemplation, the contemplation stage, preparation, action, maintenance, relapse. It's our job to kind of assess and meet our patients where they are along their journey. We need to also keep in mind that they can cycle through stages, and they usually actually will go back to pre-contemplation, contemplation. And it's because of things like challenges, like I'm not losing weight, I'm trying everything. They may have setbacks or even just like loss of motivation. And this is where we really have to use techniques such as empathy and helping them to set realistic goals, like by doing our SMART goals to really assist them. On the left-hand side of the screen, I've also included the 5 A's of obesity management from the OMA. So we want to ask our patient permission to discuss their body weight. And we do this even when they come into the office for obesity management. And when I tell people this, they're like, that's insane. No, you have to ask permission. Is it okay if I talk about your weight today? Are you ready to discuss this? You assess where they are. We advise them, we agree, we arrange, we assist. This is a collaborative relationship. I mentioned earlier a little bit about the weight promoting medications. So these are potentially modifiable risk factors. So I just highlighted here a couple that we use in pediatrics. So Benadryl, steroids, beta blockers, and the different types of insulin. So this actually really requires our providers to have great coordination between themselves and other subspecialties, because we need to basically find alternatives, or we could find a dose of the same medication that could be a little bit lower to get the same desired effect. And if we can't, then we can opt for things like mitigating medications, so things like metformin or topiramate, to help reduce the weight promoting effects of these medications. But it's always something to keep in mind when someone comes to you to discuss their weight, like what meds are they on? Are these causing weight gain? Are they weight neutral? Do they cause small weight gain? But definitely something to keep in mind. All right, so this is my favorite part of obesity, the pillars. So we have nutrition, physical activity, as well as behavioral modification and medical interventions. So for nutrition therapy, there's 5-2-1-0. So 5 servings of fruit and vegetable, 2 hours or less of recreational screen time, because we know now our kids are glued to the iPad, the TV, the phone. I've seen toddlers with cell phones. It's crazy out here. 1 hour or more of physical activity, no sugary drinks, so no sodas, no juices. Water is actually really the best thing. We also talk about the My Plate Planner. And when I was doing this presentation, and I wish I did include the Jamaica My Plate Planner, but you guys have one, and it's actually really beautiful because it really highlights local ingredients. But your plate should be half a plate of fruit or veggie, depending on the meal, or if you want to mix it up, that's fine too. A quarter of protein and a quarter of starch. If we are choosing a starch, it needs to be a complex carb. So we're talking about our brown rice, so lots of fiber, sweet potato, fig. You see on the left-hand side, there's a fat-free glass of milk or 1% milk. Typically after the age of 2, we're transitioning from whole milk to 1%, and a glass of water here on the side. With regards to nutrition guidelines, I am not a nutritionist, and I love nutritionists. I love referring to them because they have such a wide base of knowledge. I just wanted to bring and highlight here the fact that we're not introducing complementary foods until 6 months of age. if we introduce complementary foods too early, we are actually increasing the risk of our children developing obesity. So we don't introduce until 6 months or older. When you are introducing, you're picking one food at a time for a period of about 3 to 5 days. I usually tell parents, just to make it easy on themselves, just do it for a week, Sunday to Sunday, because when you have a crying baby, you're not going to remember when you started what, but you always do one food at a time. And the reason we do that is to just figure out allergies, if the child is having any kind of reaction to the food. And obviously at that point, we're not doing any eggs or cow's milk. All right, sorry, honey and cow's milk. Why did I say eggs? Honey and cow's milk. You can do eggs. Eggs and peanut butter you can do at 6 months. I'm sorry about that. What I want to highlight here is that even if you're talking about a child between 12 months to 18 years of age, we are never, ever recommending desserts, sweets, candies, soft drinks, jams, or jellies. Everything else is kind of fair game. Like I mentioned before, again, a lot of us are general practitioners, pediatricians. We have some basic nutritional knowledge, but we have nutritionists in our communities. When I was doing the presentation, I actually Googled just like, what are nutrition resources in Jamaica? There are a plethora of them. And I just picked these two just to highlight the fact that it's available and we can refer our patients there. So I think it's really important just to involve other providers. It not only gives us a chance to educate ourselves, but it really just gives our patients the ability to get more specialized care. So we cannot talk about nutrition without also talking a little bit about food insecurity. And I'm not sure if it's something that we talk about enough in the Caribbean. We know that we rely really heavily on things like food imports, not just only for our domestic consumption, but also for our tourism industry. And if we have things like shortfalls in supplies, it really does result in price hikes for consumers. And the first thing our families with low incomes will do is they're going to switch to cheaper food. So they want to get cheaper food that fills their stomach, but it's usually less nutritious. So they're going to start buying a lot more of the processed foods, the canned foods, the corned beef, the tin sausage, because that's what's cheaper and they want to be able to feed their families. So some of the things that we can do at every visit is assess something called the hunger vital sign. So you ask them, within the past 12 months, we worried about whether our food would run out before we got money to buy more, or within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So answer of yes to either one of these questions is actually a positive screen. So it's important, yes, to do these questions and to do the screening, but it's also important for us as providers to be familiar with local resources. So are there school feeding programs? Are there other governmental or church programs? We need to be aware of factors that may increase people's vulnerability to have food insecurity. So things like households with children, families that are headed by single women, less education, larger families, or even if there's like parental separation or divorce, all of those are risk factors. And above all, we also need to advocate for our patients. I cannot say this enough. Movement is medicine. So exercise is medicine actually encourages us as healthcare providers, particularly those of us in primary care, to assess and actually record physical activity as a vital sign during each patient visit and to conclude each of our visits with an exercise prescription. So on the right-hand side of the screen here, we see just an example of a FIT prescription. This is from the OMA. FIT just basically stands for frequency, like how often are you doing this exercise, the intensity, whether it's going to be moderate or vigorous. Moderate being like it's starting to get challenging, it's kind of hard to talk, but I can. Whereas vigorous is like I am sweating and I cannot get a word out. How long are we going to do this exercise for? One of your questions earlier was like, how long should a child be exercising for? An hour? The type of exercise, and then most importantly, enjoyment. Who wants to exercise unless you can enjoy it, right? So in terms of guidelines, infants need about 30 minutes of tummy time and other interactive play that's spread throughout the day. Our 3 to 5-year-olds need at least about 3 hours of physical activity per day, or about 15 minutes every hour they're awake. And then for our children 6 years or older, they need about 60 minutes of moderate to vigorous physical activity on most days of the week. It's important for us to recognize that exercise does not need to be done all at once. And if your child is not active, do not despair. You start where you are and you build from there. Okay, that's my motto. Health benefits for physical activity in children. Just a really cool little succinct slide here. So it improves strength and endurance, builds healthy bones and lean muscles. It helps our kids to develop motor skills and coordination. It also reduces fats, but I think the most important thing is that it really promotes emotional well-being for our children. So behavioral modification. We have a bunch of things on here. These are my 3 favorite ones. Modeling. Children do what they see. We cannot expect as parents to be sitting and munching on chips and cookies and KFC and not expect our children to want that. So we need to, set an example. The other thing is stimulus control. Parents will come into the office and we'll talk a lot about the child is eating cakes and candies and drinking soda. And the parent will turn to the child and say, see, I told you so. I told you not to eat that. I told you not to have the Takis. I told you not to eat the Conkers and the Zumas. But the parents are the one buying it. Children do not have jobs. So by stopping the parents from buying these things, if you don't have these things in your home, your children are not going to eat them. Children and anybody, I would. If you give me an apple and a cookie, I'll pick the cookie, and the child would do the same. So by removing these things from the home, removing the cookies, removing the chips, removing the Conkos and the Zoomers and the whatnot, and replacing those things with healthy foods, that's stimulus control, because they'll eat what's there. Another thing that we can do is goal setting or contracting. And we spoke a little bit about this earlier, but we have to ensure that we're setting realistic and achievable goals for our patients in terms of their dietary and activity goals. So we're doing SMART goals: specific, measurable, achievable, relevant, or realistic, and timed. We talked a little bit as well about screen time. Every kid has a screen. So I just wanted to put this slide in because I want to show the relationship really between the prevalence of being overweight or having overweight and daily screen time hours. So you notice here, as the daily screen time increases, so does the percent of overweight. So it's really important that we avoid using screens as babysitters. So in our patients less than 18 months, there should actually be no screen time, except for video chatting, if they're video chatting with their parent or a grandparent or like an aunt that lives away, but they really should have no screens. Between 18 to 24 months, we're doing educational programming. And what's important is that there needs to be parental involvement and participation. Between 2 to 5 years old, we're doing about 1 hour or less of screen time. And again, it should be educational. At 6 years or older, we're really trying to encourage healthy habits and limit screen time overall. And just coming back to screen time with our teens, they're usually on the phone laying in bed and they're not sleeping. So short sleep has been shown to be associated with a higher risk of obesity. And we know that healthy sleep really requires us to have not only adequate duration and appropriate timing and good quality and having like a good sleep routine, because sleep has restorative functions, right? But it also plays a central role in actually regulating our metabolism. It influences our appetite control. And that's what the slide here is illustrating for us. And it even has effects on our immune system as well. There was a study conducted by Miller et al. A couple of years ago that showed that children who go to bed late or who actually don't have a regular sleep schedule are actually exposed to a higher risk of developing obesity. So it's really important that we instill in our kids just great sleep hygiene. And we want to do that by just having regular bedtimes and wake times that are consistent every single day of the week. Like, do not be going to bed at 2 a.m. in the morning and then waking up at 6. They need to have their physical activity occurring earlier on in the day. If they need security items, whether it be a blanket or a nightlight, we can have that. Just make sure things are set up. And if we're checking on children, especially our younger kids, we should be making those checks very brief and boring. And you can see here just what are the recommended hours of sleep. And now we get onto our adjunctive therapies, so pharmacotherapy, another passion of mine. So in terms of criteria for use, you have to have class 1 obesity and a weight-related comorbidity, whether that's like fatty liver, like prediabetes or diabetes, high blood pressure, or class 2 or class 3 obesity. You need to have documentation of prior or ongoing attempts of behavior change or lifestyle interventions, and it has to occur under the care of an interdisciplinary team. The whole goal of using an anti-obesity med is basically not just to improve health, but we're improving BMI by about 5% over about 12 weeks. We want to also go back again and make sure we're minimizing that use of those weight positive medications. We want to add to our lifestyle interventions because, again, this is an adjunctive therapy. We do not do this in absence of physical activity and dietary changes. And overall, we also want to improve, reverse, or prevent complications of obesity. While our anti-obesity medications are amazing, there obviously are a couple of limitations. So very few of them are actually FDA approved for children and adolescents. Furthermore, they're pretty expensive. And insurance usually doesn't want to pay for them. And there's obviously potential for side effects as well. So I've just included a couple, the ones that are actually approved on here. So we have our orlistat, phentermine topiramate or Quercetimia. We have our semaglutide, liraglutide, phentermine, setmelanotide. The setmelanotide I put aside because it's actually for a specific type of patient that has something called monogenic obesity. And we would need an entire talk to talk about that. But it's one of those that's approved. In terms of novel therapies, we have tirzepatide, also known as Mounjaro. So that's a dual GIP/GLP-1 receptor agonist, currently in phase 2 to 3 trials for adolescents to help the reduction of BMI as well as metabolic outcomes. It really is a promising pharmacotherapy option for severe pediatric obesity. And it has basically the same side effects as like semaglutide, liraglutide with the GI side effects. And just briefly, metabolic bariatric surgery. So this is really an advanced treatment. If we're thinking about the AAP guidelines, this is really stage 4. In terms of indications, it's a child of any age, pubertal status, cognitive or intellectual disability, who presents to you with severe obesity and significant obesity-driven diseases. The BMI has to be greater than 120th percentile of the 95th percentile with an obesity-driven disease, or their BMI has to be greater than 140th percentile of the 95th percentile. What I want us to take away from this slide is that Tanner growth should not be used to determine readiness for metabolic bariatric surgery in the pediatric population. In terms of the most common ones we're using, vertical sleeve gastrectomy on the right hand of the slide is the most common one that we use. We also do the Roux-en-Y. They both have similar risks and benefits in the pediatric population. They really help in the resolution of all these obesity-driven diseases, results in higher activity levels for our kids. It really helps them to start having more or eating more appropriate portion sizes as well. They also tend to eat less while bored. It also just leads to higher quality of life and increased self-esteem, especially among our boys. We can't talk about obesity without also talking about the psychosocial consequences. So Christella is going to talk a little bit more about that. So I definitely don't want to steal her thunder. I just wanted to highlight just weight bias versus weight stigma. So weight bias is simply the negative thoughts or beliefs we have about someone because of their weight. So looking at someone who with overweight or obesity and thinking, oh, that person must be lazy. That's a weight bias. Stigma is actually the action, so how you act towards them based on your bias. So teasing them on the playground, excluding them, or treating them unfairly because of their weight. And honestly, unfortunately, as pediatricians and just healthcare providers on a whole, we've actually historically contributed to weight bias. And as clinicians, it actually is really important for us to examine and challenge our own attitudes towards children with obesity, or anybody with obesity, in fact. We have to recognize the complex interplay of both the genetic and environmental factors that influence obesity, and that will really start to help us shift from a culture of blame to empathy. And this is more than just simply changing our language. So yes, using people first language is great, but it really involves us creating environments that are inclusive. So inclusive clinical environments, so like having appropriately sized furniture and equipment, being respectful, and just overall just really avoiding stigmatizing images or messages even in our waiting rooms. Because sometimes you come to a doctor's office and there's like health and wellness stuff in the waiting room, and there's a very, very small woman on the cover, or let us help you lose fat. So you want to be mindful of these things. So by taking these small little steps, we can actually foster a more respectful, effective, and supportive relationship with families that can lead to better care and outcomes overall for our patients. And then just in terms of psychosocial consequences, and again, I won't dwell on it because I know Christella is gonna get into some of this stuff, but issues with self-esteem and body image, social challenges, mental health, there's increased rates of depression and anxiety, behavioral problems, they may have emotional eating as a coping mechanism, and it even can affect their academics as well. So just to make sure you guys are still awake, we have one more pop quiz. So first question, a 10-year-old child with a BMI at the 97th percentile and elevated blood pressure on 2 consecutive visits presents for follow-up. What is the next appropriate step in management? A, start antihypertensive medication immediately. B, order ambulatory blood pressure monitoring and assess for comorbidities. C, refer directly to cardiology. D, wait 6 months before reassessing. How many seconds do they have left, Sam? Okay, great. So we order, awesome. You guys were awake. I love it. In the evaluation of pediatric obesity, which of the following comorbid conditions should be screened for during the initial workup? Dyslipidemia and impaired glucose tolerance, elevated transaminases only, hypothyroidism exclusively, vitamin D deficiency.
And here are the results.
Great job. They were awake and paying attention. I love this. All right, and last one. Which of the following is an appropriate indication for initiating pharmacological therapy for pediatric obesity per current guidelines? A, class 1 obesity with no comorbidities. B, class 2 obesity with unsuccessful lifestyle interventions. C, a BMI at 85th percentile for age. D, mild weight gain over one well visit.
You have 10 seconds, guys. Please remember, if you have any questions that we're about to try to go into, please type them in the Q&A, and the results are in.
Perfect. You guys did so great. I love it. And these are just references. Thank you guys so much for listening. I'm just going to stop sharing screen right now.
Thank you so much, Rashida. You did a fantastic job. It felt like we were learning or drinking from a fire hydrant. There was so much information. It's great. From the assessment of obesity to the tools that are available. I really appreciate the tools that you know, highlighted. History examination, lab tests. You went through the whole gamut of exercise, diet, sleep, and even screen time. So really appreciate all that. And we have some time here for question and answer. So I'm going to open it up for question and answer. And anything that's not done, we can ask Rashida to answer in online. Okay. So Sam, do you want to go through those questions? Well, I have them up here. Can you discuss water consumption for children within age range?
That I'll be honest, I usually just look it up, so I can look it up really quickly for you. But it's also not something I feel like we discuss quite frequently. But in terms of just introducing water, you can introduce water at 6 months of age. I usually say 1 to 2 ounces or just a small amount. I'm trying to pull it up for you. But healthy hydration. I can come back to you. I'll give you the link for that.
Okay, great. Thanks. Gail reads us, I noticed the expected emphasis of triglyceride and LDL for dyslipidemia. What of total cholesterol if LDL and triglyceride are normal?
So we would actually just repeat it and just keep an eye on it for that case. Like we would just really just emphasize just diet and probably just have them come back in a month or so just to repeat it fasting.
Okay.
Typically in our patients with obesity, they have this combined dyslipidemia. So they have those elevated triglycerides, those low HDLs, and like their total cholesterols are either normal or moderately elevated. And that's typically the pattern that we see. And that's also the pattern that you see with insulin resistance as well.
Okay, great. Shante Howell asks your thoughts approaching parents of kids with Down syndrome who are overweight. They feed to avoid behavioral problems.
So I think that with a patient with Down syndrome, you really have to also work with a behavioral therapist as well, because you're really just using at that point food for a coping mechanism. So are we offering them high calorie snacks instead of like trying to find healthier alternatives? I think it's important to get your other ancillary providers involved just to kind of figure out, okay, like how do I move away? How do I shift this child on a different path. And I think CC actually would have like really good tips for that. So I think we could circle back to that question as well.
Okay, great.
Right.
What are your thoughts on breastfeeding obesity?
Breast is best. As I mentioned before, AAP really does encourage us to breastfeed exclusively for up to 6 months and even up to beyond 2 years if mom and baby are amenable to doing it. If you have an infant that is considered as overweight or obese, you don't starve the baby. We literally just monitor them over time. But you can continue to breastfeed if I hope that's what the question was like trying to get at. You don't stop breastfeeding even if the child is obese or overweight.
Okay. Toddler milk is strongly promoted, high in sugar and fat. Is it ever okay to advise starting it? Whole milk is a better choice.
Whole milk, yes, is a better choice. So we see it here in the, because I work in Brooklyn, we have a large Caribbean population as well. And they will have the nido. So you'll ask them, how are you mixing it? They'll probably just be mixing it until it looks creamy. So they're really giving their kid a ton of extra calories that they don't need. So we never ever recommend doing it. I would prefer them just do whole milk because they also just tend to end up mixing it incorrectly anyway.
Great, fantastic. And how useful is measuring body fat percent in this population?
So as I mentioned, we typically, in terms of gold standard, DEXA is the way that we would measure that. I've never used it in the 2 or 3 years I've been doing this. It's just very expensive and very difficult to set up. And BMI is just a better way of just doing it over time. So I've never used DEXA in a pediatric population. I think also because it's so expensive, many facilities just don't have it. And a lot of times, because we're also using insurance here in the US, you're going to have a really hard time getting them to pay for that.
Okay. And how does stress affect obesity in children and in Jamaican children?
So stress is a really big factor, right? Because if you're stressed out, you might be either overeating or undereating. You're going to obviously opt for things that are going to give you that sugar high. So you're picking those high calorie foods. Again, I think Christella's also going to touch on this as well, but stress plays a huge role in our eating patterns and what we choose to eat. So it's important for us, I think, to limit stress, or even teaching our kids methods of how to cope with stress as well is going to be a very important thing for us to be doing.
Great, great. Well, I think we've answered quite a few questions. And we're gonna go ahead into our sponsors presentation from Nestle before we get into the next presentation. And any other questions that you have for Rashida, go ahead and put it in the question and answer section. So, Nestle.
Good day, and thank you for joining us for another Nestle education session exclusively for healthcare professionals. The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. In this session, we will focus on a distinguishing component of the NAN formulation, optimized protein. Developed through advanced protein modulation, this feature, alongside probiotics and human milk oligosaccharides, HMOs, supports optimal growth and metabolic programming during early infancy. OptiPro, a unique protein optimization technology, reduces adipogenic activity by extracting casein glycomacropeptide, CGMP, which lowers insulinogenic amino acid levels and brings the essential amino acid profile closer to that of breast milk. This ensures better protein quality and quantity for optimal infant growth. Non-OptiPro features an amino acid profile that closely resembles that of breast milk, supporting infant growth patterns that align with the WHO growth standards for healthy development. Evidence from global research indicates that a high protein intake during early infancy is associated with accelerated weight gain and an elevated risk of obesity later in life. Let's take a look at a few. This study by Gunther et al. Examined the association between protein intake during early childhood with body mass index and body fat percentage at 7 years of age. The findings revealed that higher protein intake, particularly from dairy sources, during early life was linked to increased BMI and higher body fat percentage in later childhood. This prospective cohort study by Pimpin et al. In 2016 investigated the relationship between dietary protein intake and subsequent body mass index and weight in children up to 5 years of age, using data from a twin cohort based in the United Kingdom. The findings suggest a significant association between higher protein intake during early childhood and increased BMI and weight gain over time. Non-OptiPro delivers high-quality, age-appropriate protein levels tailored to support optimal growth and development. Stage 1 is formulated to closely align with the protein concentration found in breast milk, while stages 2 and 3 adhere to the protein requirements established by the Codex standards for follow-up and growing up formulas. Additionally, non-OptiPro provides a high ratio of whey protein closer to breast milk than our competitors, demonstrating faster gastric emptying with only 26% of the volume remaining after 2 hours. We also have the standard DHA and ARA with the required quantities and ratio present. This ensures the development of brain tissues and retina during these early years. Choose non-OptiPro when breastfeeding is not possible for the benefit of OptiPro to prevent metabolic malprogramming associated with too much protein. With Nestle's verified platform of macro and micronutrients balanced for everyday growth and development. Here are a few references to support our presentation. For any questions, please reach out to your Nestle representative at the number below via telephone or app. Wishing you a productive and enjoyable session. Goodbye.
We want to thank Nestle again for being our sponsor for tonight. And this time we move into our second presentation, Mental Health in Pediatrics, Recognizing and Managing Emotional and Behavioral Disorders. And this will be done by Cristela Durasco. Cristela is a licensed clinical social work candidate with over a decade of experience in child and adolescent education. She currently serves as a psychotherapist at the Mgmt Pediatric Clinic in Brooklyn, New York, where she provides compassionate, evidence-based mental health support to young individuals and their families. Mrs. Durasco utilizes trauma-informed and strength-based approaches to address a range of mental health concerns, including adjustment disorders, anxiety, ADHD, and depression. Her practice is rooted in creating a safe, inclusive, and supportive environment for children and families to explore and address emotional and behavioral challenges. A key area of our work includes supporting children struggling with obesity, helping them navigate the psychological and emotional complexities associated with the condition. And through her dedicated efforts, Mrs. Durasco remains committed to empowering youth and fostering resilience within the communities that she serves. Without further ado, Cristela, go ahead.
Good evening. Thank you for such a lovely intro. And thank you, Dr. Andrews. That was a lovely presentation. I aim to make this as quick, painless, and insightful as possible. I saw that we were sounding off in the chat, and as someone with 10 years of educational experience, I love that. So please continue that as we go through our presentation today. It is my hope that we will be able to identify common diagnoses for youth and lead with actionable interventions to assist with youth living with these conditions. So let's get into the top diagnoses that I see in my practice working in Brooklyn. And number one is anxiety, generalized anxiety disorder. autism spectrum disorder, adjustment disorder, attention deficit hyperactivity disorder, and depression. It is not uncommon to see several of these things all at the same time. I have several patients that have 1 to 3 of these diagnoses all at once. So let's get into some of these definitions. Depression is a mood disorder that causes a persistent feeling of sadness and loss of interest. Attention deficit hyperactivity disorder includes difficulty paying attention, impulsiveness, and restlessness. Adjustment disorder, excessive reactions to stress, and they're usually short-term and situational. Adjustment disorder often mimics depression and anxiety, but the difference is that adjustment disorder is typically a response to something that's just happened. So for example, a transition. If a child has undergone a large transition, we'll a lot of times see adjustment disorder. Autism spectrum disorder is a complex neurodevelopmental condition affecting communication and social interactions. Right. On our screen are several symptoms of each, well, of 4 of these diagnoses. The 5th one being anxiety, and that's going to be the one that we touch on the most. But we can start with depression and the common symptoms. So feelings of sadness, angry outbursts, and lack of energy. Autism spectrum disorder, challenges navigating our social environment, repetitive movements, behaviors, or interests. Adjustment disorder includes crying often, having trouble sleeping, and not eating enough. And attention deficit hyperactivity disorder includes impulsiveness, disorganization, and problems prioritizing, poor time management skills, and problems focusing on a task. Now, a lot of the work that I do with families and children is listening to parents kind of complain to me about their kids, right? So they come in with these large complaints and they're often at their wits' end because we know there's a large stigma about seeing therapists in the community. So when they come and see me, they're usually at their wits' end. Like they've tried their best, they've prayed their best, and they're like, okay, we can talk to this professional that is in the pediatric clinic. So they come in with a lot of complaints, and a lot of my work is to listen to these complaints and validate the experience because, of course, living with someone who does not have an actual diagnosis or a name for their behavior can be very, very frustrating. So as I'm listening to the complaints, I'm listening for symptoms. So I want you guys to do the same. I'm going to kind of be a parent who complains to you, a medical professional, and in the chat, you can sound off on which diagnosis you think fits the complaints of this parent. All right, so we have a little Johnny. Johnny will not look at company when they come to the house, even if they come to the house to see him. Johnny would rather go into the cupboard and rearrange the cupboard. He rearranges the same cupboard every single day, the same row on the cupboard every single day. Which diagnosis do you think that might be based on the symptoms on the screen? All right, yes, autism. Okay, you guys are awake and with me. I love this for me. Little Jackie is always crying about how much she misses her friends back home after moving from Mexico to the US. We think Jackie is sleeping. However, Jackie is watching TV until the wee hours of the night. When we offer Jackie anything to eat, she doesn't want anything to eat, but maybe a Taki or maybe some crackers, but she will not have any actual meals. Adjustment disorder is sounding off in the chat. Excellent. All right, Tommy is withdrawn. Tommy does not want to talk. When mommy comes to talk to Tommy, she's just like, he's so angry, he's so upset. I can't say anything to him. When I ask him to wash a dish, he acts like he can't move. I don't know what to do with this boy. What do we think that is based on the complaints that I'm giving? All right, depression. Yes. Excellent. All right, we have little Madeline who just will not sit still. Her eyes are always darting when I'm talking to her. When I ask her to do something, it's like she cannot hear me. I have to repeat myself 16 times. I'm tired, doctor. What's wrong with my child? Okay, I'm seeing ADHD. Yes, excellent job. Excellent. So, yes. Okay, awesome. Yes, thank you. Thank you all for your participation. So a lot of my job is listening and validating what I'm hearing, but also giving appropriate language to what's going on. So let's talk about noticing the signs of anxiety, because this is one of the largest diagnoses that I work with in my practice. A mom will come in and tell me that her daughter has an attitude problem. She has anger issues. That girl can't follow no instructions, won't eat anything. The girl, I can't talk to her. She just thinks she's grown. So what I'm hearing mom say is, okay, she's highly irritable. She lacks focus. And it sounds like she has a lack of appetite and energy, mom. This is all congruent with anxiety. Do you think that that might be something that happens with her? And mom will usually answer like, yeah. I'm like, does she get a little squeamish around new people? Does she be withdrawn? And I start asking more questions so that I can give parents better language as to when they're talking to their children. Earlier in the presentation, Dr. Andrews spoke about people first language. And so I do a lot of reframing for parents to make sure that we're using people first language. All right, so anxiety. And this is kind of going to be like a sample session with a psychotherapist of what it might look like with me. Anxiety is intense, excessive, and persistent worry and fear about everyday situations. In the chat, can you sound off on when these types of emotions, or when this emotion in particular, might come up for you? What example can we offer? Oh, I'm a bit frozen and I'm trying to access the chat. Okay, there we go. An exam, absolutely. I got exam twice, school exam, yep, a new job, absolutely. Public speaking, yes, absolutely. A musical performance, meeting deadlines, wanting to go to school and interview, yep. Absolutely, yes. The most common example that I like to use, a new step parent. Oh, that's a good one. A doctor's visit. Oh, a doctor's visit is very, very anxiety provoking. You guys are right. Presentations, driving, change in family dynamics. Yep, one parent leaving, absolutely. Oh no, I'm sorry. Let me go back. New school, a blood test. You guys are on a roll. Thank you. Thank you so much for your participation. The common example that I like to use with my patients and family when I'm explaining what anxiety is that I ask them to envision themselves in a jungle. And if a tiger was running after you in a jungle, what would you do? You guys are free to kind of answer that question in the chat as well. I'm kind of curious about your answers. Run, yep, flying, absolutely. Run, pass out, Run, might freeze, drop dead, absolutely. Freeze, hide. Die, yep. I get that answer too. Panic attack, yes. Okay, you got scream, climb a tree. Fight and flight mechanism, yes. Run, find a tree, climb it quick. Absolutely, I love these answers. So I get these types of answers all of the time, and I'm sorry that I keep going forward. So I get these types of answers all the time, right? The kids will tell me they're going to run, they're going to kick, they're going to scream, they're going to yell, right? And that's a very appropriate response because you are in a jungle and there's a wild animal that can really tear you limb from limb, right? It is a life or death situation. And so you do what you have to do to make sure that you survive. Now, that is a more than appropriate response for that situation. However, children being children have similar responses to things like tests, to things like new people, to things like doctor's visits. I can't tell you how many times I'm sitting in sessions with my patients and there are babies screaming because they see the needle. The needle has not touched their bodies, but they see the needle and they are screaming for their lives. My job is to teach, not babies, but to teach children from ages 6 to 21 more appropriate coping mechanisms, right? I explain to them that anxiety is unsafety. Anxiety is your body sending you the signal that something's not right and we have to be on high alert and we have to do something. So when you are feeling anxious about a test, instead of screaming and kind of throwing a tantrum, what do we do to calm our bodies down? That's my goal with the children, to help them regulate themselves, regulate their emotions, and regulate their nervous systems. When you feel unsafe or anxious, regulating your nervous system brings you back to safety. So we do a lot of cognitive behavioral therapy and a lot of cognitive reframing and helping them understand what the actual facts are in the situation. So some of my favorite therapeutic tools to help my kids come back to safety or come back to their bodies, because a lot of times they're out of their bodies when they think about this difficult thing, right? The fact of the matter is the test is difficult, but it will not kill you. The fact of the matter is this person is new, but they will not kill you, right? If at any point you feel like you're in danger, do what you must to get out of that situation. However, when we are in spaces where we know nothing is going to harm us, we've got to remind our body that nothing will harm us. They know cognitively, like, okay, the pencils are not out to get me. They know the paper's not out to get me. The sharpener in the room cannot harm me. So what in the room is actually causing you distress, and what in the room is actually going to cause you bodily harm? When they let me know that it's nothing, then I know that we've got something going on, and our bodies need to be able to respond to that. So I like to give them these exercises to kind of help their minds and their bodies come to an agreement. So 5 fingers, these are all discrete, by the way, and so they can do them under their desk. They can do them as they walk. They can do them in a way where no one is going to notice that they're actually in turmoil, and they don't have to have a big outburst, right? So 5-finger breathing, and I'm not sure if you guys want to participate in this part of this, but what I would have them to do is to breathe in as they go up 1 finger, pause at the top, and then breathe out as they go down the next finger. And they breathe in through their nose, pause at the top, breathe out through their mouths. And depending on their age, I'll start to use different analogies, like, all right, let's breathe in and make your belly like a balloon. And then let's pop that balloon and as we breathe out and make our bellies flat, right? Or I'll say, you know, let's breathe in the flowers and let's blow out our birthday cake, depending on the age group. So they do that so that they can bring their minds and bodies to an agreement that we're okay. 3 to 5 cents grounding, depending on how old they are and depending on what the condition is. I have them identify 3 to 5 things they can see, 3 to 5 things they can hear, 3 to 5 things they can touch, 3 to 5 things in the room that they can smell, 3 to 5 things in the room that they can taste. Now, I usually keep the taste out because, you know, during an exam, there's not much in the room that you can taste, but sometimes I'll have them think about their favorite foods and bring them back to their bodies. So the purpose of this, and the reason why I do 3 to 5, is that if you have ADHD, I'm not going to ask you to do 5 of anything. I'm going to start you off with 3, sometimes maybe even 2. If you're 6 years old, I'm not asking you to do 5 of anything. I'm going to start you off with 3, maybe even 2. And I ask them to identify these things around the room. The purpose of that is so they recognize that there's nothing in the room that's actually going to bring them danger. Now, if at any point they're in a space where something might actually bring them danger, I encourage them to do what they must do to survive that interaction. However, during the test, nothing is going to actually harm you. The test is just difficult, and difficulty does not mean death, at least not in their grade. So I have them to do that so that they can come back to their bodies and come back to what the reality is of the situation. My favorite is box breathing, where they have them breathe in for 4, hold for 4, and then breathe out their mouth for 8. While we're in the office, it's very exaggerated. So I have them breathe in for 4, hold for 4, and then I ask them to breathe out like a fire-breathing dragon, depending on their age. And I want to hear an audible breath out of their mouth to make sure that they're doing it right. These things are relatively discreet. If they need a room to do this, they can do it in a room separately if they want to ask the teachers for things like that. However, it can be done anywhere, anytime, and no one really has to notice. And that is all for me. Thank you.
Wow, short and sweet.
I promise to make it painless, quick and painless.
That was great. Loved it. Loved all the practicals. I loved the definitions. Loved how to identify. So let's go to our question and answer and see if we have any questions there.
None at the moment.
Yeah, we'll give it a time or two.
Thank you all.
That was great. I really love that. Very simple, very clear, and things that we can all use with our grandchildren and our patients. So fantastic.
I'm not sure what the literacy rate is in Jamaica, but I know that in the US, most people don't read past a 4th grade level. So I like to make things as basic and as simple as possible so that anybody can grasp it. Your mom, your dad, the baby, anyone can grasp the concept and be able to run with it.
Yep. great. I loved your example about a wild animal. You know, what would you do if a wild animal was in the place? So you can identify very clearly, you know, the signs of anxiety in a kid, and that things
I have
around
a question here.
you. All right, go ahead.
So the question is, how do you differentiate between insecure attachment and anxiety symptoms?
They show up very, very similarly. They show up extremely similarly. So differentiating them is rather difficult because they show up the same. Somebody who is anxiously attached, well, attached to something. So if they're attached to, if they're not positively attached to their parents or securely attached to their parents, they're going to attach to something else. So they might attach to that iPad, they might attach to TikTok, they might attach to that TV. So it all kind of looks the same.
Great. Just a reminder to put your questions in the question and answer section so that we can make sure that they all get answered.
That was an excellent question.
Mm-hmm. Okay, what if a child goes into tantrum and anxiety when asked to do a task?
Then we enter co-regulation. So any of those 3 tools that I just taught the group, you can use with the child. It's still important to hold boundaries with children because they are going to try and test their limits, and it's developmentally appropriate for them to do so. As parents or as adults or as the people who are the people who are in charge of these little people in their spaces, it's important for us to let them know, hey, it's okay for you to feel upset. Here's what we can do to help you, right? They're going to tantrum and it's going to take you a lot of practice, but here's what we can do to help you, right? And so you do it with them, you do one of the tools with them. I always suggest doing the deep breath. If they're really in a big tantrum and they just can't do a deep breath, fine, that's okay. Punch a pillow. Go ahead and get all this anger out on this pillow here. You can go ahead and karate chop this pillow, but what we're not doing is throwing a remote. What we're not doing is throwing cups, right? We're gonna hit the soft item because it can't hurt you and you can't hurt it. And it'll help you get the energy out. And then you can ask them to let you know when they are ready, and you can give them a command for when they're ready. So I just told a parent today when the child is kind of going into her own tantrum and you're trying to help her de-escalate and she just refuses to de-escalate, you stay in the room because connection is what they need and attention is what they want. And even if you're yelling at them, it's still the attention that they want, but that's not what we want to continue doing with them. You stay in the room with them and say, hey, when you're ready, you can pick up Mr. Cutie, which is her stuffed animal, pick up Mr. Cutie, and you and Mr. Cutie and I can clean up whatever mess that we've made, or, you, Mr. Cutie and I can do this task together.
Okay, great.
So to put it in formula, I want to always make sure that I am encouraging that you connect before you correct. So get in there and acknowledge what you're seeing and allow them to correct you if that's not what their emotion actually is, and connect with them and help them co-regulate. Don't let them do it alone.
Okay, great. Awesome. So we have a question here: how to set boundaries with a child who has autism and is very attached to a screen and is fidgety.
So first of all, I want you to regulate yourself because you're going to be extremely frustrated a lot of the time. It's going to take a very long time to get them out of a screen addiction. Screens are very, very chronic and a really, really big issue, and the kids love it. So what I'm going to encourage is that you self-regulate. So you might want to use one of the 3 tools, or maybe all of the tools before you engage that child. And you let that child know, hey, you have 5 more minutes on the iPad, and then you can pick one of 3 activities. It has to be 3 activities they enjoy. So you can't say, hey, we can wash a dish. If it's not fun for them, that's not what they want. Especially a child with autism, they like the same 6 things. So pick one of the 6 things that they enjoy and let them know that they can play with that. And then I would start to just decrease screen time every week. We cannot just snatch it from them and expect that they're going to respond well. It's just not going to work. So what we want to do is decrease the amount of screen time that we're using. And like Dr. Andrews said, we want to have educational programming. We want to have them talking to relatives because they need help with social interactions. Or we want relatives to maybe send videos that they can watch or look at pictures of themselves and their family so they can start to identify who is who and what's what if they're nonverbal.
Great tips. How can exercise help in these various situations?
Oh, it can help greatly. A lot of times parents will come in and be like, I think my child has ADHD. And I'm like, I'm going to prescribe them soccer because I don't think they have ADHD. I think they need to move their bodies because they're in school for 8 hours a day where they're asked to sit still. And it's just not developmentally appropriate. But I can talk blue in the face about how school systems are not really set up for children's best advancement. but that wouldn't get us anywhere. So absolutely sign kids up for sports. It is important for them to learn how to be on a team, to be around other people, and to get all that energy out so that they're not in your house tearing it up.
Great. Wonderful, wonderful. Trina asked, apart from the three you mentioned, do you have other tools that can be used to teach emotional regulation to toddlers?
I have plenty of tools. How long do we have?
Well, sky's the limit. You just made a very short presentation.
So it really depends on the space. If we're in public, we want to talk lower and slower to the child. So don't start getting big and start yelling, because they're going to meet you exactly where you are. So as the adult, you set the temperature. So if they're kicking and screaming and yelling, you want to come very close to them and talk to them in a really, really slow and lulling voice, like, hey, I see you're upset, or try to name whatever emotion that you think they're going through. I think it looks like you're upset. Are you upset? What's going on? We can talk about this. The cookie can't come with us if you act like this. We can't have sweets if you act like this, because sweets make you crazy. So I can't give you any sweet, right? This is me talking to them, but you talk to them how it works for you. And you validate the feeling that they're having, let them know it's okay to have it, and let them know that you're here to help co-regulate with them when they're ready and speak with them when they're ready.
Great.
If you're at home and you're doing that whole tension thing, I love having them karate chop pillows. I used to work in a school where we had like bean bags. And so what I would do is put them between the bean bag and make them a sandwich. And it's like good proprioception for their bodies. So we do like a whole, like, I shake them in the sandwich and everything, and like act like I'm putting on sauce and act like I'm, kneading a dough. And they loved it. They would go from like tensioning to like laughing. And we want them to move from one emotion to the other, a more positive one. And once they're doing that and they're laughing, you can reconnect with them like, hey, like that was a really big emotion and very, very scary. What happened? And how do we make sure that doesn't happen again?
Great. Awesome. How do you treat a child who has a diagnosis of ADHD and is attached to the device to the point of sneaking the device in his room and not sleeping at night? Okay, so I guess they're still sneaking the screen into their room. I guess it would be nice to know how old this child is.
Yeah, well, where is it and how can they get it, right? If it's in your room, how are they getting it out of there? So I would advise that we get very creative about where we put the device. And I would also narrate through the night, like, hey, you have 10 more minutes left with this device. Let's make sure that we're wrapping it up, because we are not going to see it again until tomorrow morning. And then give them another activity to do, so maybe they can read, maybe you guys can play a game together, do something that connects the two of you so that they're not as connected to the phone. Do things to connect to their kids, because what they're looking for is connection at the end of the day. It's hardwiring for them to want to attach to something or someone. And if the someone isn't there, the something is always going to be there. So be it the phone, a substance, whatever it is, they're going to attach to something. So you make sure they attach to you as the parent. Make sure they attach to themselves as human beings, and just do things that will connect yourself to the child. And then be very creative about how you hide that phone.
Great. Good advice. Good advice.
I also want to encourage like nighttime routines that they enjoy, that they can be part of. So absolutely incorporating play at nighttime, making sure there's like dim lighting. You can do candlelit dinners. It sounds romantic, but it's really nice. It's just really nice thing for children to enjoy. It is low sensory stakes. And so it's just nice to go from that straight into bed, and from going from large screen TV to small screen.
Gotcha. Good stuff. To what extent does criticism influence anxiety in a child?
Largely. So if you criticize first, they're going to shut down. Our brains are not necessarily wired to receive negative things first. So that's why we always encourage the sandwich method. So we say a good thing, and then we say the criticism, and then we say a good thing again, so that they're getting mostly good things. And then the criticism is in the middle. So it doesn't feel like you're attacking them. It feels like, okay, there's something I need to work on. I do things well, and there's things that I can work on as well.
Good. Excellent. We have, I think we're at the end of our questions. You did a great job. Thank you so much, Christelle. At this time, we're gonna move into our sponsor's presentation, Indus Life Sciences, and it will be followed by another presentation from Nestle.
Good evening, doctors. Mr. Sam, can I share my screen?
Hold on. Hi, Mr. Daya. Yes, you can go ahead.
Thank you. Not able to see my screen.
Not yet, no. Are you sharing?
Yeah, that's what I'm trying, but I don't see my desktop screen on it.
Um, Interesting. Click share screen again. Tell me what comes up.
I see the entire screen, application windows.
Okay, so you're at the top where you have screens there. And you have desktop one.
No, basically it is my desktop is open. Okay, let me try it again.
Sure.
Oh, I have to click the share. Right, I got it now. Thanks.
No problem.
You're able to see the screen?
Yes, we are.
Thank you very much. Good evening, all. Thanks to the AGPJ for this wonderful opportunity for Indus Life Sciences. And I'm pretty sure everybody knows Indus. For those who do not know what is Indus, INDUS, which stands for I and Us, we together. I and Us is Indus. So we have a wonderful range of pediatric products. So I take this opportunity just to refresh some of the brands that is being detailed to you all. One of our product is for productive cough. We have plenty of cough expectorants in the market, and the brand which I'm going to share stands out among other brands because of the wonderful combination it offers. This offers as a Viscofes, as you could see in the screen, is a cough expectorant from Indus. It offers three major ingredients, specifically the ambroxyl, which is basically the mucolytic drug. The role of ambroxyl, it breaks down the mucus, the thick sputum that is secreted during productive cough. It breaks it down. And salbutamol, we all know it's a bronchodilator. It dilates the bronchioles. And the guaifenesin is an expectorant. It basically expels the sputum. So if you notice it, ambroxyl breaks the mucus, sputum, salbutamol open the airway, and guaifenesin expels it. So it's break, open, expel. They work in synergy. So when your patients have productive cough, specifically pediatrics, this combination will really help your pediatric who having chesty, wheezing, asthmatic, and productive cough. The highlighting point is that the ambroxyl is superior than that of bromaxin. I'm not bashing bromaxin. The main benefit of ambroxyl is that it has a surfactant action. The surfactant action is basically means it enhances the receptors that is present in the alveoles, thereby any antibiotic that is co-prescribed with Viscofes, as because it has ambroxyl, it enhances the antibiotic action. And the salbutamol in Viscofes is 2 milligram per each 5 ml. Why I'm highlighting this? Most of the brands that we currently have in Jamaica offers 1 milligram salbutamol. Here it is 2 milligram for each 5 ml. The benefit is that unlike other expectorants with Viscofes, you do not need to recommend 10 mils for adults or 5 mils for kids. Here, when it Viscofes, you can just recommend 5 ml 3 times a day. If you recommend 5 ml, they get 2 milligram salbutamol for each 5 ml. So they get 6 milligram for the adults, which is a therapeutic dose, and children, basically it is 2.5 ml. So the end benefit to the patient, and 100 ml bottle will last literally for 7 days. Rest of the cough expectorants, trust me, your patient has to buy 2 bottles. With Viscofes, 1 bottle, that means they save huge amount. So this is a surfactant action which I just highlighted, enhances the antibiotic action. And I'm not bashing here, just look at the different preparation of cough expectorant that is popular across Caribbean. You could see Viscofes offers 2 milligram salbutamol for each 5 ml. So dose is just 5 ml 3 times a day for adults, and 2.5 ml is sufficient for children. And 1 bottle will last literally for 7 days. And we have a wonderful antibiotic, cefuroxime acetyl. that is our Intil. That's our cefuroxime. Here, the highlighting point is the suspension. This is the first brand of cefuroxime in Caribbean available with the fruit punch flavor. Why I'm mentioning fruit punch is that this antibody is wonderful antibiotic, but one of the disadvantage with cefuroxime is that is bitterness. Specifically, when I work in Bustamante, a lot of pediatricians has expressed when they recommend cefuroxime, the kids specifically, either they spit it or throw it because of the bitterness. What we did, we masked the bitterness with the fruit punch. So it makes it more palatable, and thereby, kids will not spit or, throw it. So this is the only brand in Caribbean available with the Caribbean flavor, true Caribbean flavor, that is a fruit punch. And Intil suspension is also now in Wendlist, so it's available in all drugstore stores. And for your pediatrics who have stomach upset or, acidity conditions too, of course, adults too have experienced a lot. Heartburn, hyperacidity, gastritis, gas problem, acid reflux. We have this wonderful antacid from Indus, which is the third generation basically with the alginic acid benefit. I'm pretty sure all of you are aware of the benefit of alginic acid. Alginic acid basically stops acid reflux. So GERD basically, we are almost in dinner time. Many of us will have a nice belly full. And then when you lie down, it throws up. And when the intensity is high, it disturbs the sleep. And sometimes it causes panic of, even worried about a heart attack. So when you have Nugel, your sleep is assured. Good night's sleep is assured. Because of the alginic acid that is in Nugel, it stops the GERD by forming a raft called as alginate raft. You could see in the screen. There's a small clip that explains exactly how does this alginic acid stops acid reflux. Thereby, there's no heartburn, specifically at bedtime. You are ensured of good night's sleep and sweet dreams too. This is how the alginic acid works. It reacts with the stomach acid content and the alginate raft is formed. It blocks the entry of stomach content into the esophagus. N number of attempts the stomach content makes, every time it is blocked, and it is formed in just 4 minutes and action sustained literally more than 4 hours. After that, it gets completely excreted with no residues left. This is the first antacid in whole Caribbean, offers the benefit of alginic acid, thereby it stops GERD. Magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, we know the role. It neutralizes acidity. Dimethicone relieves gas. And the highlighting point for pediatrician, it's safe in children, even less than 10 years. If there is a need for an antacid, you can depend on Nugel. And the brand itself conveys the message Nugel, which means new generation antacid gel. And I'm not bashing again. You could see how many nil with other brands and where Nugel stands. Nugel offers the best composition currently in Jamaica, of course, in Caribbean. The last brand which I like to refresh is our Amino Pep, which is also referred as Jamaican Tonic. The only brand in Caribbean, specifically in Jamaica, which offers not only the vitamins, but also the amino acids kids require. The arginine in amino acids helps for healing. Histidine, as you could see, we know it very well, promotes hemoglobin production. Lysine is good for kids for growth. Even, picky eaters, it opens up the appetite. And specifically, phenylalanine is very, very important for kids, those who are taking CXC exam or PEP exam, or, are there any other university exams, because it promotes concentration and memory. And tryptophan is ideal for all medical practitioners, paramedics, because your stress is too high, and tryptophan is a stress buster amino acid. It can reduce your stress. That's the benefit of tryptophan. Plus, it has all vitamins, as you could see, B1, B2, B6, B12, vitamin E, vitamin C, vitamin D. It has calcium. It has zinc, which has 50 milligram. COVID time, we talked a lot about the benefit of zinc. And the dose of zinc in amino peps, the most therapeutic dose of 50 milligram, that could help. It's something like a booster dose when you're taking amino pep. So that's, as I discussed, children have more pressure than us. mentally, physically, because Jamaica is a sports country. Not only academically, we even expect the kids to do excellent in sports. So amino pep can help your child to perform both academically as well as in sports. 5 ml once or twice is sufficient, and adults normally it is 10 ml once at bedtime or maximum twice depending on the need. And again, you could see which brand stands tall among all supplements that we have currently in Jamaica. Nothing can come close to amino pep in terms of composition, and of course, price-wise, most affordable too. So the last slide is this, the healthy tips, that's very, very important. We have been taught so much in the school, some of the key for healthy lifestyle: exercise, at least 30 minutes of brisk walking, nutritious food, vegetable and fruits in our diet, and adequate water, and at least 6 to 7 hours of sleep. And last but not the least, please take up amino pep that gives pep to your step. That's our amino pep, is available in all pharmacies with the chocolate flavor. That's our amino pep. For samples, please WhatsApp to this number. We'll definitely reach out to you and give enough samples, whatever you require. Thank you very much.
Thank you, Indus, for your presentation and for your sponsorship. We go into Nestle's presentation.
And welcome to another Nestle education session for healthcare professionals only. The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. As our next generation of Jamaican babies grow at different pace, we only communicate responsibly with our valued healthcare professionals who can make the best decision for each patient on a case-by-case basis, from breastfeeding to supplementing where necessary and transitioning to complementary foods at the correct time. Our final group of products are designed to aid the little patients in your care to transition from their liquid start to solid foods after 6 completed months via semi-solid cereal solutions. A key nutrient identified during this transition is iron. Babies are born with sufficient reserves depicted in green and continue to receive a maintenance amount via breast milk depicted in gold. At approximately 6 months, the reserves are rapidly consumed during normal growth, reducing their levels and putting them at risk for iron deficiency depicted in red. Only an iron-containing diet at 6 months can replenish these stores to facilitate continued healthy growth. Or Nestle infant cereals with the high bioavailable element iron from ferrous fumarate coupled with 6 times as much vitamin C provides a framework to aid this transition to solid foods while bridging the gap in essential nutrients until they are fully established on everyday solid foods with their balanced nutrient needs. Nestle cereals contain more than 50% of the daily iron requirement of a 6-month-old in a single serving, at least 16 vitamins and minerals, along with probiotics, and no refined sugar added. But all our variations remain the same great taste and consistency babies 6 months and older love. Here are a few of the references for the studies supporting our features and the benefits our little patients can get from choosing our brands. For any further questions, please reach out to a Nestle representative at these numbers via telephone or WhatsApp. Do enjoy a fruitful conference. Goodbye.
Thanks again to Nestle for your sponsorship. It's what makes us be able to put on these activities, and really thank you. Can't thank you enough. This time we're going to have a general question and answer session. It doesn't have to be too long. I know our guests are about an hour ahead of us, so we'll just open it up for any final questions that you want to pose to either Rashida or Christella about obesity and mental health. And we want to thank you so much for your presentations. It was really very, very enlightening. Okay. Chat. Okay, you're getting lots of hand claps here. All right. Any other questions?
Not seeing any questions. Would anybody like to ask a question live? You can just raise your hand and we can open your microphone. Nope. Great presentations is what we're
Yes.
seeing. Hand claps. You know what? You guys need to present not as good next time.
Thank you so much, Rashida. Thank you so much, Christella. We really appreciate your presentations. Tonight would not be what it was without both of you here. So we want to thank you both very much for taking time out in your schedule to present to us. We really appreciate it. As you can see, your presentations were well received, and we were definitely able to follow along and learn tonight from both of you. We want to also thank our sponsors, Nestle and Indus Sciences. We want to thank Sam from Allgate Solutions, who is always there for us and was handled the platform so well. Thank you for putting in those poll questions, Sam, at the last minute. I really appreciate that. Really made it more enjoyable. And we want to thank Lynn for our administrator for helping to organize and orchestrate this. Of course, we wouldn't be able to have this without our president and our executive team, our president, Donald Gordon, who wasn't able to be live with us today, although I know he's listening in. We are so grateful for his leadership and his foresight. And I don't think there's anybody else that we need to thank. We need to thank our participants who logged in tonight. We appreciate the time that you've taken, and we want to see you back for another session with us as the Association of General Practitioners, as we try to provide answers and solutions for us in our medical practice. Thank you so much. Have a great night. Wonderful time.
Night, everybody. Have a wonderful one. Thank you, Dr. Subi. All right.
Thanks,
Cheers,
Sam.
everyone. See
Night, night.
you. I think it's next week. We see you at part 2 of this series. Cheers,
Great.
everyone.
Cheers.
Thanks for having me.
Night, 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 Rashida.
Good night.